Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections.
Yeah, glad to be diving into this one today.
Because today we're actually tracking a silent bacterial hitchhiker. And the terrifying thing is about 1 in 10 people are carrying it right now without even knowing it.
Just kind of waiting for the exact right moment to strike.
Exactly. Just waiting to cross into the bloodstream and, turn deadly in a matter of literally hours.
I mean, it really is the ultimate biological ambush. There's no other way to describe it.
Right. So picture this scenario. It's a Tuesday morning. You've got a healthy college student living in like a crowded dorm, or maybe a military recruit in basic training.
Super common settings for this, yeah.
Right. So they wake up feeling like they're coming down with just a standard run-of-the-mill flu. They have a fever, their muscles ache, they feel a little wiped out, nothing crazy.
Nothing that would make you rush to the ER.
Exactly. You pop an ibuprofen and you just drag yourself to class. But by the afternoon, things take a very, very dark turn. They physically cannot touch their chin to their chest.
That neck stiffness.
Yeah, and a strange, dark, purple rash is blooming across their arms and legs. And if you press a clear glass against that rash like an actual drinking glass, the purple spots don't fade or turn white.
They stay stubbornly purple.
Which is terrifying. And by nightfall, so less than 24 hours after that first mild symptom, they are on a ventilator in the ICU fighting for their life.
The speed of that progression is, well, it's what makes this pathogen so deeply terrifying to medical professionals.
Yeah.
I mean, you are looking at a disease that can completely overwhelm a young, healthy human body from sunrise to sunset.
It's hard to even wrap your head around. So to figure out how something like that is even biologically possible, we've pulled together a huge stack of sources for this deep dive.
We've got clinical data, WHO roadmaps.
Yeah, historical case studies, epidemiological research. We are going to map out exactly how this bacteria operates, how it literally breaks into our nervous system, and what global health experts are doing to stop it.
Because it's a massive effort right now.
It is. Because when I was reading through the clinical data, the best way I could describe this bacteria is it's like a sleeper agent.
Oh, that's a perfect analogy.
Right. It lives completely peacefully in the back of your throat, undetected, causing absolutely no trouble to you at all. But then some environmental trigger gets pulled.
Something tips the scale.
Yeah, and the sleeper agent activates, crosses the blood-brain barrier, and launches a total, all-out assault on your central nervous system.
The villain we are profiling today is officially Neisseria meningitidis.
Neisseria meningitidis.
Yep, it's a type of bacteria known as an aerobic gram-negative diplococcus. And one of the most crucial things to understand right out of the gate is that it exclusively targets humans.
Just us.
Just us. We are its only host. There is no animal reservoir out in the wild. You don't get this from a mosquito or a bat.
Hold on, I have to stop you there for a second. Gram-negative diplococcus sounds like, I don't know, a spell from Harry Potter.
It does a bit.
In plain English, what does that actually mean for the way it attacks us?
Fair question. So diplococcus just refers to its physical shape. If you look at it under a microscope, these bacteria look like 2 tiny coffee beans stuck together in a pair.
Okay, coffee beans, I can picture that.
And gram-negative refers to the armor they wear. Their cell wall has a very thin structural layer, but it's wrapped in this outer membrane that contains built-in toxins.
Wait, built in?
Built right in. When the bacteria dies and breaks apart, it sheds those toxins directly into your body.
So even when it's dying, it's doing damage?
Exactly. It's a kamikaze mission.
Wow. And when that sleeper agent goes rogue, the sources outline 2 main forms of meningococcal disease that it causes.
Right, depending on where it sets up camp.
Yeah. The first is meningococcal meningitis, where the bacteria infect the tissue lining your brain and spinal cord, causing massive, agonizing swelling.
And the second?
The second form is a bloodstream infection known as meningococemia, and that's when the bacteria enter the blood and, according to the clinical descriptions, literally chew up the walls of your blood vessels.
Causing bleeding directly into your skin and internal organs.
Which explains that terrifying purple rash we talked about in the cold open.
What's fascinating here is how the bacteria actually pull this invasion off. Neisseria meningitidis has at least 12 distinct serotypes.
Like different families?
Essentially, yeah, different bacterial families. And they're categorized based on the unique structure of their polysaccharide capsules. The most dangerous ones worldwide are serotypes A, B, C, W, X, and Y.
Okay, the alphabet soup of doom.
Pretty much.
Yeah.
And that capsule is the pathogen's secret weapon. Think of it as a biological invisibility cloak.
So when it first enters the bloodstream, the body's security guards, like the white blood cells, they just don't see it.
Well, they see something is there, but the capsule is it's slippery and structurally deceptive. It physically prevents the host's immune system, specifically the phagocytes.
The ones whose job is to eat foreign invaders.
Right, those ones. It prevents them from grabbing on and destroying the bacteria.
Yeah.
It basically buys the pathogen critical time to multiply unchecked.
It just sneaks right past the guards. That is wild. And humanity has been fighting this invisible enemy for a really long time. I saw in the timeline it was first officially discovered back in 1887
Yeah, over a century ago.
by a scientist named Anton Weichselbaum. He actually isolated it from the cerebrospinal fluid of a patient who had meningitis.
And since that discovery in 1887, we've been able to map its global footprint, which sadly is heavily concentrated in one very specific tragic region.
The meningitis belt.
Epidemiologists call it the African meningitis belt. It's this massive, sweeping stretch of land across sub-Saharan Africa, stretching all the way from Senegal in the west over to Ethiopia in the east.
And that region historically suffers the absolute highest burden of the disease.
Unbelievably high. It's prone to these massive recurrent epidemics that just sweep through communities.
I noticed that geographic link in the research, and it made me wonder why this disease is so heavily tied to specific regions or even specific events, because the data also shows massive global outbreaks of serotype W, I think.
Yes, serotype W.
Right, and those were directly linked to the Hajj and Umrah pilgrimages in Saudi Arabia. What is the connection there? Why those events?
If we connect this to the bigger picture, it all comes down to human movement, climate, and proximity. The ultimate historical catalysts for this pathogen are mass gatherings, high-traffic border areas, and high migration events.
Because it's an exclusively human pathogen.
Exactly. When you have millions of people from all over the world converging in one crowded setting, sharing space and air, and often in dry, dusty climates.
Oh, wait, the dust matters.
Huge factor.
Right.
The dry, dusty air irritates the mucosal lining of the throat, creating microscopic abrasions. It makes it so much easier for the bacteria to take hold. It creates the perfect breeding ground.
That makes a lot of terrifying sense.
And the stakes couldn't be higher, because without treatment, the historical mortality rate for this disease climbs to a staggering 50%.
Half. Half the people who get it die. That is a coin flip you do not want to take.
Never.
Which makes understanding how it spreads incredibly important, and the transmission route is, honestly, shockingly mundane.
It's everyday stuff.
Yeah, it's spread through respiratory droplets and throat secretions. We are talking about sharing saliva, kissing, or just living in the same household and sharing the same breathing space.
And up to 10% of the population are asymptomatic carriers right now, just harboring it harmlessly in the upper throat.
So wait, I need to push back here. Earlier you said it's spread through respiratory droplets.
Yes.
Does that mean if someone coughs next to me on the subway, I'm like ending up in the ICU tomorrow? Because that is a terrifying thought for anyone taking public transit.
No, and that's a really important distinction. It is not as contagious as the common cold or the flu or, COVID. You aren't likely to catch it just walking past someone in a grocery store or sitting near them for 10 minutes on a train.
Okay, phew. So what does it take?
Transmission requires sustained, close, or lengthy contact. You really have to be in someone's space. But once that contact happens, the incubation period is a very tense 1 to 14 days.
And when it finally makes its move, when that sleeper agent wakes up, the micro battle that takes place inside the body is absolutely ruthless.
It really is. The bacteria use structures called pili. You can think of them as molecular grappling hooks.
Grappling hooks.
Yeah, they literally shoot these hooks out to lash onto your mucosal cells.
So it anchors itself into your throat, so it can't just be swallowed or flushed away by mucus.
Exactly. And once anchored, it has two main paths of destruction. It can cross the cribriform plate of the ethmoid bone.
Which is where?
It's basically a direct, highly porous backdoor route through the roof of your nasal cavity straight into the brain.
Oh, I hate everything about that visual. Straight through the roof of the nose.
It's a fast track. Or, the second path, it enters the blood and unleashes an endotoxin called lipoligosaccharides.
Okay, lipoligosaccharides. That is a massive medical word. What does that chemical actually do to a person when it's unleashed?
It acts like a biological grenade. Remember that toxic outer membrane we discussed earlier, the gram-negative armor?
Right, the kamikazes built-in toxins.
That's the lipooligosaccharide. When the bacteria release this endotoxin, it interacts with your immune cells and triggers a massive shock-inducing inflammatory storm.
Like sepsis.
Exactly like sepsis, it essentially tricks your immune system into overreacting so violently that your body releases chemicals that cause your capillaries to leak fluid, your tissues to die from lack of oxygen, and your major organs to just shut down.
It's using our own defense system to destroy us. Okay, let's unpack this and look at who actually takes the heaviest hit from this biological grenade, because the demographics in the sources are very specific.
Very heavily skewed.
Infants under 1 year old face the highest incidence rate, by far. About 2.45 cases per 100,000 people. I guess their immune systems are just completely naive at that point.
Completely defenseless, yeah.
Then there's a second spike among teens and young adults, specifically ages 16 to 23, and finally, adults over 65.
And those age spikes, particularly the teenagers, map directly onto socioeconomic and environmental risks.
Because of the crowding.
Exactly. Think about where 16 to 23-year-olds live. College dorms, fraternities, military recruits in packed training facilities, close quarters, shared cups, high stress, a total lack of sleep weakening the immune system. I mean, it is a buffet for Neisseria meningitidis.
And we also have to mention the occupational hazards, microbiologists working in clinical labs.
Yes. If they are exposed to aerosolized particles during testing without proper face shields, their risk skyrockets. We've seen tragic lab-acquired cases.
I also noticed in the research that there are some deeply specific medical vulnerabilities, like people living with HIV are highly vulnerable. But the one that really caught my attention was individuals without a spleen, a condition called asplenia.
Right, because the spleen acts as a massive blood filter for encapsulated bacteria.
Yeah.
So without it, you lose your main defense against that invisibility cloak we talked about.
And there was also a really surprising warning about certain medications.
Yes, this is a huge one for clinicians to watch out for. People taking specific complement inhibitor medications, drugs like equilizumab, which is sold as Soliris, or ravulizumab, sold as Ultomiris.
It blew my mind because these are life-saving drugs for people with rare blood or muscle disorders, right? But the way they work is by suppressing a very specific part of the immune system.
The complement cascade.
Yeah, and unfortunately, that suppressed part just so happens to be the exact defense mechanism the body uses to fight off meningococcal bacteria. It's like turning off the security cameras in the exact hallway the thief uses to break in.
That's a great way to put it. And once the thief is in, the speed of destruction is what keeps doctors up at night. For adults, medical schools always teach the classic triad of meningitis symptoms.
Right, the big three.
A sudden fever, an altered mental status like deep confusion or lethargy, and neutral rigidity, which is a stiff neck.
And the neck gets stiff because the lining of the spinal cord is so inflamed that literally just stretching it by tilting your head causes agonizing pain.
It's an unmistakable searing pain.
But the clinical data makes it clear that the reality on the ground is much messier than a textbook. That classic triad only appears together in about 44% of cases.
Less than half.
Yeah. You cannot wait around for all three symptoms to show up before calling 911.
You absolutely cannot. The guideline suggests that if a patient has just 2 of 4 key symptoms, fever, headache, stiff neck, or confusion, it successfully flags 95% of cases.
Better safe than sorry, always.
Always. You also want to look out for photophobia, which is an extreme, painful sensitivity to light.
Mm-hmm.
And then, of course, there's that late-stage purpura fulminans.
Which means what, exactly? Lightning fast purple?
Quite literally, yes. It is a hemorrhagic rash. Because the blood vessels are leaking and the body's clotting system just goes totally haywire, blood pools under the skin.
And that's why it passes the glass test.
Exactly. It doesn't fade when you press on it because the blood isn't in the vessels anymore. It has already leaked out into the surrounding tissue.
God, that's grim. We also really need to talk about infants because their reality is completely different. Babies do not exhibit those classic signs. You can't ask a baby if they have a headache or a stiff neck.
No, you have to look for entirely different behavioral cues. Extreme inactivity. Are they unusually slow to wake up? Are they highly irritable with a weak, continuous cry?
Do they have poor feeding or abnormal reflexes?
And most notably, doctors look for a bulging anterior fontanelle.
That is the soft spot on the top of a baby's skull.
Because the plates of the skull haven't fused yet, right? So the intense pressure building up from the inflamed fluid in the brain actually pushes that soft spot outward.
That is a terrifying visual for any parent. Which brings us to the medical emergency. The clock is ticking so loudly at this point. This disease requires immediate, aggressive, intensive care.
Total all-hands-on-deck situation. The gold standard for confirming the diagnosis is a lumbar puncture, commonly known as a spinal tap.
Right, where they go into the spine with a needle.
Yep. Doctors need to extract and analyze the cerebrospinal fluid, the CSF, to see exactly what is happening in the central nervous system.
And when they test that spinal fluid, it looks like a microscopic war zone, because normally CSF is perfectly clear, right? Like water.
Crystal clear.
But in bacterial meningitis, the opening pressure of the fluid is dangerously high. It's under pressure. And the glucose levels, the sugars, are drastically low, dropping below 45 milligrams per deciliter.
And that's happening because the bacteria are literally eating the sugar in the fluid for energy to multiply.
They're feasting on it. And the protein levels will also be sky high, above 500, which, according to the sources, is just the debris. It's the fallout from cellular death and massive inflammation.
And to top it off, the white blood cell count will be off the charts, over 1,000 per microliter, as the immune system desperately sends thousands of soldiers to a battle they are already losing.
But, and this is a critical rule highlighted in all the public health guidance we looked at, doctors cannot wait for that spinal tap to come back from the lab.
Oh, absolutely not. They don't even wait to perform the tap if it's going to cause a delay in treatment. Antibiotics must be administered immediately.
Do it now. Ask questions later.
Exactly. If bacterial meningitis is even suspected, the first dose of antibiotics goes in right away. We are talking about heavy-hitter drugs. Third-generation cephalosporins, which work by physically ripping apart the bacterial cell walls. Yeah, given alongside broad-spectrum drugs like vancomycin. They also administer intravenous corticosteroids, like dexamethasone, right at the exact same time.
To deal with the swelling.
Right, to try and chemically shut down that deadly brain inflammation before it causes permanent, irreversible damage.
But despite all of that firepower, the reality is incredibly sobering. Even with perfect, rapid, state-of-the-art medical treatment in a top-tier ICU, 10 to 15% of patients will die.
It's just too fast.
And for the ones who survive, 1 in 5 will face severe, lifelong sequelae. We're talking about limb amputations because the blood supply was cut off by that hemorrhagic rash and the tissue died, profound deafness, permanent seizure disorders, severe brain damage.
It completely alters the entire trajectory of a survivor's life. The psychosocial impacts, the long-term physical rehabilitation, the need for prosthetics. It is a devastating aftermath.
Here's where it gets really interesting, though, because we aren't helpless against this. We don't just have to wait for the infection to happen and then scramble to treat it.
No, we have proactive tools.
Vaccines are our absolute best defense, and we actually have a highly effective arsenal. There are multivalent conjugate vaccines known as menacwi, which protect against 4 of the worst strains.
And we also have protein-based vaccines, the MenB vaccines, specifically targeted at serotype B.
And the global triumphs of these vaccines cannot be overstated. I mean, the numbers are incredible. Since 2010, the massive deployment of the mRNA conjugate vaccine across the African meningitis belt has been an incredible success.
It essentially eliminated serotype A epidemics in vaccinated regions. Just wipe them off the map.
That's amazing. And just recently, in 2023, the World Health Organization pre-qualified a brand new pentavalent vaccine called Men5CV.
This is a huge deal.
Pentavalent meaning it covers 5 strains.
Yes. It protects against A, C, W, Y, and X. Rolling out this single, powerful vaccine has the legitimate potential to make large-scale epidemics in the African meningitis belt a thing of the past.
Just one shot to cover all of that. It is a monumental scientific achievement.
Truly.
But until the whole world is vaccinated, we still have to rely on strict infection control to break the chain of transmission when an outbreak does pop up.
Right, it's Public Health 101. That involves a rapid response from local health departments. Anyone who is a close contact of an infected person. Roommates, kissing partners, even people sitting directly next to them on a long airplane flight.
Anyone who shared their air.
Right. They must receive antimicrobial chemoprophylaxis.
Meaning preventative antibiotics.
Exactly. A rapid dose of ciprofloxacin, rifampin, or ceftriaxone. Ideally within 24 hours of exposure, but up to 14 days after. The goal is to chemically eradicate any bacteria that might have just moved into their nose, halting the transmission dead in its tracks before it can cross into the blood.
Stop the sleeper agent from waking up.
Exactly. And in the hospitals, it means strict droplet precautions. Masks, face shields, isolation rooms. You absolutely do not want clinical staff getting exposed to respiratory droplets while trying to save a coding patient.
Which brings us to the present moment. Where are we now with Neisseria meningitidis? In the United States, routine vaccination schedules have been a monumental success.
The data speaks for itself.
It really does.
Yeah.
The incidence rate plummeted from 1.2 cases per 100,000 back in 1996 down to just zero point 0.1 in 2018.
It is a testament to public health policy working exactly as intended.
But the threat is lingering. It hasn't completely vanished. In 2022, the CDC reported a sudden spike in cases specifically among individuals with HIV, largely due to gaps in vaccine coverage in that community.
And globally, it is still a major, major public health challenge, particularly in areas dealing with high migration and the massive crowded conditions of refugee settings.
Because the bacteria thrive on displacement.
Yes. When infrastructure breaks down and people are crowded together without access to vaccines or clean air or sanitation, the sleeper agent wakes up.
So what does this all mean for our future? The global mission is clearly defined by the WHO. They've launched a highly ambitious global roadmap called Defeating Meningitis by 2030.
It's an aggressive timeline.
Yeah, the three main goals are to completely eliminate bacterial epidemics, drastically reduce vaccine-preventable cases by 50%, and cut total deaths by 70%.
It is ambitious, but with tools like the new Men5CV vaccine, it is absolutely possible. But this raises an important question. We are living in an era of unprecedented global crises. Climate change, conflict, extreme economic instability.
Right.
And these crises are forcing mass migrations, creating more crowded, under-resourced refugee settings and highly congested border areas. As human geography changes, will the traditional historical boundaries of the meningitis belt begin to shift?
Will it expand?
Exactly. Are global health systems agile and funded enough to track, trace, and treat a sleeper agent pathogen that travels invisibly across borders, hidden safely in the throats of perfectly healthy people, moving faster than our laboratories can even process the tests?
That is a chilling thought. It's a pathogen that doesn't need an animal vector. It doesn't need a swamp or a mosquito. It just relies on us breathing the exact same air.
Our need for connection is its weapon.
And as the world gets more crowded and more transient, the opportunity for that biological ambush only grows. That is something to think about the next time you find yourself in a crowded room. Stay informed, stay prepared. This has been Outbreak Brief.